A listener production.
Hey there, I'm Bension Siebert, and this is your afternoon briefing. Medicare is part of our identity as Australians. It's a bit like our gun laws, or the way we do elections, or how we use a kettle rather than a microwave to boil water. We like to think it makes us better than the Americans. But of course, it's more important than that. Before we had universal healthcare in this country, medical bills were the number one cause of personal bankruptcy. Now, if you get cancer or you're in a car accident or you need major surgery, part or all of that will be covered. This month, as Medicare turns 40, people are looking at this system with new eyes. Is this thing still fit for purpose? Does it cover what we need it to cover? In this afternoon's episode, we're going to hear its relatively unknown origin story at an Aussie barbecue in the 1980s, and we find out what could be done to keep Medicare in good health for the next 40 years. Here's the briefing's Sacha Barbour Gatt speaking with Kees Van Gool. He's a professor of health systems and policy at the University of Sydney.
Kees, first off, welcome to the briefing. Before we get into the nitty-gritty of Medicare, I've heard this story that Medibank, which was the first version of Medicare that Gough Whitlam came up with, it was born at a barbecue. Is that true? And can you tell us the story?
Yes, the legendary barbecue is certainly a factor in Australia's universal healthcare system. So we're celebrating 40 years of Medicare, which was introduced in 1984. But in fact, as you said, Medicare has a predecessor, which was Medibank, which was introduced in 1974. So it's actually 50 years since Medibank, 10 years apart. And to go back to how Medibank was introduced, you've got to go back to a barbecue that Gough Whitlam attended back in 1967, where he met two academics, John Deeble and Dick Scott from the University of Melbourne, where he basically said, look, I'm really interested in introducing universal healthcare into Australia, but it's got to be within the confines of the Australian system, within what we already have, within the laws and the Constitution of Australia, so that it can't be eradicated or removed again through High Court challenges as such. Because prior to that, there had been so many various attempts already at introducing forms of universal healthcare system, which were always continuously challenged.
Was Australia kind of leading the pack at that time when it came to universal healthcare, or were we kind of modelling off other countries?
Universal healthcare was something that had been sort of introduced in a lot of other countries by that stage. So we were a bit behind, and particularly by 1984, we were very much behind. A lot of the wave of universal healthcare sort of came in the post-World War II era. England went to the NHS, and a lot of other Western European countries went to universal healthcare. So by 1974, we were sort of lagging behind, and certainly by 1984, we were sort of lagging behind. And now I would say, with the exception of the United States, basically all OECD countries have universal healthcare.
So how come we ended up with Medicare and not Medibank? What was the difference between the two systems, and what changed so that we were given Medicare in 1984?
So the two are really similar. So it's the same sort of design. And when you think about universal healthcare, it's been like a patchwork. So we've built in pieces over time. So, for example, the pharmaceutical benefit scheme, which is a really important part of the universal healthcare system, that sort of got introduced in the 40s. It changed a little bit in the 50s, but essentially it's been part of the fabric for, over 70 years now. So that was cemented. We had public hospital insurance, essentially free public hospitals as we now know it, in the late 40s, early 50s. Then it was dismantled, and then we picked it up picked it up in 1975, and it was dismantled and picked it up in 1984. So it's been this continuous sort of backwards and forwards, 2 steps forwards, 1 step back, 2 steps forwards. But it wasn't until 1984 that we can now recognise Australia's universal healthcare system as we now recognise it. It was the last big piece of the puzzle, and this time the puzzle stayed. Basically, up until John Howard in 1996 essentially agreed to keep Medicare as it is, it has been contested political space. It's a bit like, climate change and electricity policy in this country now. It's just always backwards and forwards, and legislation gets passed and it gets repealed and all sorts of things. So think of universal health insurance in that space between the late 40s and 1984.
We've talked it up, but there are definitely issues with Medicare as it stands now. What are some of the biggest problems with the program and what needs to be done to make sure that it is still viable and still working in another 40 years?
It's a patchwork, right? So you can think of universal insurance as sort of three dimensions. The first dimension is what proportion of the population is covered. And Medicare does pretty well because we cover most people. There are really only some visa classes that it doesn't cover. And even for those visa classes, there's a requirement that they purchase private insurance. So that's a dimension that's covered pretty well. The second dimension is what services are covered. Now, here, we do pretty well, but not everything is covered. Typically we don't cover over-the-counter medicine. We don't cover forms of plastic surgery. But the one big bit that's still missing is dental care. So dental care is one aspect that is still a missing piece of the puzzle. There have been various attempts to include dentistry into the Medicare package, and we do have some insurance for it. So there is some public dentistry, and of course privately you can also insure for dentists. But I think everybody would agree that this is a part of the system that is underinsured. The third dimension is basically the depth of the coverage. So to what extent does insurance cover each service that you're paying? And so if it's not insurance, then it's co-payments, right? So you've got to pay out of pocket. And so that's always an issue in the Australian setting, particularly if you're claiming for things like GPs or diagnostic images or particularly specialist care. So I would say in terms of services, dentistry is a particular issue, and in terms of the sort of depth of the Medicare, out-of-pocket costs for some particular services is still an issue as well.
What's happening in the space now when it comes to planned changes to Medicare and its features? We saw last week that the amount of GPs that are bulk billing did actually increase for the first time since 2020 off the back of the Labor government increasing the incentive for doctors to do so. So that's a policy change there. Are there any other movements in the space that are going to see those things you just mentioned either brought in or talked about on the halls of Parliament?
There's a lot of focus on GP bulk billing rates in the general public debate. And that's right. We all go to the GP, so it's a really important issue. The incentives seem to be working. So, it was the Howard government in 2004 that sort of introduced the first bulk billing incentives, which had it was a very similar sort of story. Years of declining in bulk billing rate and incentives then came in along with a sort of a rise in the MBS. So that's been part of the story. And then, of course, yes, the Labor government recently introduced the bulk billing incentives, or it basically tripled the bulk billing incentives, and that now seems to be having an effect. The next challenge is obviously we want to see the bulk billing rates keep going up. This is very early numbers, yet it's, first of all, it's arrested the decline and it's kicked up a little bit. So we want to see that keep going. But there are still certain areas where, you could think of things like specialist care where access is still an issue. So when we measure equity in the system, GPs, and this is based on slightly older data, but GP care is fairly equitable. Public hospitals is equitable, but specialist care is still favoured by higher income people compared to lower income people. So that's an issue that needs to be addressed.
How safe is Medicare? You mentioned before that it's kind of been picked and pulled apart over the years. There have been legislation brought in and legislation axed. How safe is it? Are we going to continue seeing Medicare? It'd be pretty unpopular, I'd imagine, to do anything really fundamentally different to Medicare.
Look, up until 1996, this really was a contested space, and it featured a hot debate every election about who was going to govern and what the plans were for Medicare. But it was in 1996 where we could essentially put Medicare in the trophy cabinet, that, this was an essential part. And true to the words, that is what happened. As I mentioned before, the decline in the bulk billing rate that happened in the sort of mid-90s was arrested within the coalition government through a major funding injection for bulk billing and the rise in MBS. So I think as we know it, it's there. I think the challenge is more around how do we make sure that Medicare keeps up with the changing dynamics of the healthcare that we need. Because I think the way the system was designed in 1984, it served a different population, a different demographic, and different healthcare needs. As we've aged, we've become more chronically ill, so more chronic diseases that require multidisciplinary care over longer periods of time, right? And of course, there's been an enormous technological change as well. And the health system needs to sort of be able to incorporate those changes, make the best use of the technology, and change to make sure that we're looking after people in a multidisciplinary way over longer periods of time. And that's where I think the funding system still needs to sort of reform in order to keep pace with the changing needs of Australian patients.
Absolutely. I, for one, as I said, am very grateful to have Medicare. I wish it a very happy 40th birthday, and I toast many, many, many more happy years with it. Kees, thanks so much for joining us today and for giving your insights.
My pleasure. Thank you.
Kees Van Gool there. He's a professor of health systems and policy at the University of Sydney, speaking with our very own Sacha Barbour Gatt. That's all for your afternoon briefing today. But wait, there's more. The weekend briefing with Antoinette Lattouf will be live in your feed tomorrow. Antoinette, who do we have on this week?
This week I chat to a self-described introvert who also happens to have 16 million TikTok followers. It's Caleb Finn. He went from working in early education to making viral horror videos, and he gives lots of fascinating insights into what it is like to be a full-time content creator and whether there's such a thing as too morbid for the internet.
Thanks for that, Antoinette. And we're keen to hear your feedback and guest suggestions for the show. Hit us up on Instagram by searching The Briefing Podcast, hit follow and send us a DM. There you'll also find the Behind the Briefing broadcast channel, where we give you an insider's look at making the show and special bits that you won't find anywhere else. I'm Bension Siebert. Have a great weekend.